Everyone. Extra early for us today, but I guess a normal time for Dr. Schmidt. It is my great honor to introduce our Grand Round speaker here for December, Dr. Bogdana Schmidt. Dr. Schmidt is a urologic oncologist and assistant professor at the University of Utah Huntsman Cancer Institute. Dr. Schmidt earned her medical degree here at UCSF, where she also completed her general surgery internship and urology residency, followed by a Society of Urologic Oncology fellowship at Stanford University. Dr. Schmidt's clinical interests are very broad across all urologic cancers, and her specific interests for research include risk stratification, optimization of surgical outcomes, quality improvement. More recently, you may have seen her on all over Back Table Urology, where I've really enjoyed her commentary and discussion and made a huge splash in non-muscle invasive bladder cancer. On a more personal note, I remember Dr. Schmidt when I was a medical student. She was a TA in my anatomy lab. And then I followed her into urology residency where she was my R2 during sub-I. And Dr. Schmidt's always stood out for her incredibly empathic care of patients and a razor sharp intellect. So I am really looking forward to her discussion today with us on risk, recurrence, and response, navigating the NMIBC landscape. Thank you, Dr. Schmidt.
Carissa, thank you so much for the very, very kind introduction. I'm incredibly honored to be giving this early Grand Rounds talk. It's always a little scary to give Grand Rounds at your home institution where everyone in the audience has impacted my care of patients, my training, my view on urology as a field. So thank you so much for welcoming me back for this, and I'll try not to disappoint. So these are my disclosures. It is extremely daunting to cover all of non-muscle invasive bladder cancer in an hour. It's ambitious. So I'm going to try to focus on risk factors, stratification, some diagnostic techniques, and hopefully highlight some future directions and how this field will evolve to better suit our patients. So just basic epidemiology, bladder cancer is still the sixth most common cancer in our country. Non-muscle invasive cancer is the majority of bladder cancer diagnosed. And even though in recent years, the trends of prevalence of bladder cancer has been trending down, actually this year, the ACS report is predicting a 2.2% overall increase in bladder cancer patients. So if we talk about risk factors for bladder cancer that we know, smoking has been the one that we've been talking about to our patients for a very, very long time. Also occupational exposures, and certainly some environmental exposures that we know about, like arsenic. If we focus on cigarettes and smoking a little bit further, we talk about some known risk factors within it, right? We know that cigarettes have nicotine, though that's not necessarily the cancerogenic part of it. If you break it down further, you can see all of the very scary poisons that are contained within a cigarette, including methanol, carbon monoxide, and arsenic, which we know is a known bladder cancer risk factor. The rates of people starting to smoke are dropping, but the rates of e-cigarettes are rising. So Dr. Bierland's group at UNC started to ask the question, are there carcinogens in the urine of e-cigarette smokers? And could that be contributing to some of the rising rates of bladder cancers, given that traditional smoking rates are decreasing? They looked at 40 different parent compounds, identified several metals and unique toxins in the metabolites, and they found that there were at least 6 carcinogens that were strongly linked to bladder cancer in the urine of e-cigarette smokers, like pyrene, naphthalene, phentermine, toluidine, naphthalamine. Certainly other metal and unspecified risk factors were also found, though these have not been directly linked. Still a little bit early. This is just relatively early data and has been corroborated in mouse models and empirically looked at in urine, but certainly no prospective studies have been done in the space. E-cigarette users appear to have carcinogens in the urine that are linked to bladder cancer. And certainly this may play a role in precipitating the development of bladder cancer, but I think it's still relatively early work for figuring out how we can reduce some of these toxic components that are making it into the urine of these smokers. Certainly telling people to stop smoking would be great, but we've been doing that for a really long time with moderately favorable results. So if we move on from the risk factors, we can talk a little bit more about diagnosis. Bladder cancer tumors are usually identified on imaging and cystoscopy. Our staging is done surgically with TURBT. And once we have that staging, we risk stratify the patients. This is the AUA risk stratification. It's in the guidelines looking at how we identify low risk, high risk patients, intermediate risk. I want to bring your attention to high-grade TA tumors because in the AUA risk stratification, these patients fall into intermediate risk. However, there was just a great debate at the SUO last week talking about whether this really is where this patient group belongs. And if you look at the IBCG risk stratification, it actually breaks it down a little bit differently. It puts every patient with a low-grade TA tumor that is a solitary primary tumor in the low-risk category, any patient that has high-grade CIS or variant histology in the high-risk category, and anyone who has a high volume or recurrent low-grade tumor in the intermediate risk category. I like this because I think it's a little bit more anatomic and pathologic friendly, having it be a little bit less of a hodgepodge in the intermediate risk group. And the nice thing about this risk stratification is it also gives treatment guidelines. So you have these risk categories, and then you evaluate risk factors. Does the patient have multiple tumors, early or frequent recurrences, larger tumors, or prior treatment failures, and get a point for each of these. So if you have 0 risk factors, the treatment is your TURBT with a perivesical chemo dose, and you could consider office fulguration or observation in an appropriately stratified patient. If you have 1 to 2 risk factors, you do the perioperative chemotherapy after the resection. Primary treatment recommendation is induction chemotherapy, especially in the BCG shortage. BCG is second line. And if you have a high-risk patient with 3 or more risk factors, you do your TURBT, you have your induction BCG with maintenance up to a year, or intravesical induction chemo with maintenance as second line. So this all looks really straightforward. You get the path, you risk stratify the patient, you have all your treatment guidelines. Unfortunately, we know that recurrence rates are still very high and progression rates are up to 10 to 20%. So what is it about these tumors that makes this happen? Well, we know that in low-grade tumors, recurrences are more prevalent than progression. We know with high-grade TA tumors, up to 30 to 40% can progress to T1, and up to a quarter can progress to T2. T1 tumors, up to a quarter of all non-muscle invasive tumors at presentation, and they have a worse prognosis, and we'll come back to this as well. CIS, despite being a flat lesion, has an independent metastatic potential with very high rates of recurrence and progression. When we counsel patients, how do we talk to them about risks of recurrences and progression? This is based off of several meta-analyses and retrospective data looking at factors that predict recurrence, multifocality, prior recurrences, so behavior of the tumor is consistent. Certainly factors that predict progression, like I said, CIS, high grade, high stage, and size are more important than number of tumors and how frequently they have come back. So what do we do about this? I just said we have a risk stratification system, but we have this problem. Well, there's a couple ways to think about this. Some of it, strides we've made, some of it, directions we still need to improve. Well, you can't treat what you can't find, right? If we talk about tumors that recur, progress, if you undertreat the tumors, then certainly the outpatient's outcome will be worse. So this is where we'll talk a little bit about blue light cystoscopy, and certainly everyone in the oncology side at UCSF is very well familiar with it, but we'll talk a little bit about the data. So when TURBT is performed only with white light, up to 20% of patients had recurrent tumors that were only found with blue light. So you are not seeing some tumors with white light alone. In the operating room, up to 34% of CIS has been detected only with blue light cystoscopy. This is all based on retrospective data. When you look at the randomized trial data, you see that in publication, it said there was no difference in progression detected between the two groups of white light or blue light. However, only 13% of the patients in this trial had CIS, and we know that for CIS, it makes the biggest difference. And the trial was published prior to full enrollment. So as much as we can say randomized trials are level 1 evidence, and certainly they warrant respect and being discussed, I think in this trial in particular, it was not designed well enough to answer the questions that it really should have been answering. Namely, can a blue light be helpful in this patient population? And if it is helpful, can it ultimately change outcomes? Clinically, this is obvious, and these are Dr. Porton's slides, but they're excellent, where you can see that on this white light cystoscopy image, maybe you could have found this papillary tumor fairly easily. Maybe you could have seen this papillary tumor if your lights were turned down, but there are several small tumors that easily would be missed with white light alone that you can see quite clearly on blue light. And this is papillary. This is where we say that we don't need blue light quite as much. But when it comes to CIS, it gets much more complicated. So when you have patients who have had BCG before or other treatments in the bladder that have caused some inflammatory changes, you can see these erythematous lesions that can be quite confusing. This is a white light image of a patient post-BCG where the entire back wall looks like it could be CIS. But on blue light, none of this lit up, and this ended up just being post-inflammatory changes. This is a very similar looking patch, just slightly smaller on white light, and you can see on blue light here, it lights up bright. When I teach my residents about blue light cystoscopy, I'm a big fan of the scratch test. So when you take the loop and you basically cold swipe over the tumor and you start to see if tumor cells or hot pink little bubbles start to float. If the hot pink bubbles start to float, that is a real tumor. That is a lesion that is concerning for cancerous cells. If when you swipe it, the whole pink thing moves with the bladder, that is less likely to be a true cancerous lesion. So that's finding more. What about staging more accurately? Well, staging drives treatment. We said that in the beginning that this is how we stage these tumors. How do we do this better? Is there a better way to do a TURBT? Several groups have looked at this and noticed that TURBT quality is a real metric. Younger surgeons, resident surgeons, are more likely to leave residual tumor behind, more likely to lack detrusor muscle in the specimen. And when you don't have muscle in the specimen, the residual tumor rate is quite high. And you can see that when residual tumor rates are higher, patients do worse. The mortality goes up when muscle is not in the specimen. So doing a high quality TURBT is very important. Re-resection matters as well. This is a study out of MSK almost 10 years ago that looked at 1,000 patients who had restaging TURBT performed on 87% of them, and 55% had viable tumor on restaging TUR. At 5 years, the only predictor of recurrence was having only a single TUR done. And this was for all high-grade patients, so high-grade TA, high-grade T1. This is pretty impressive. In my practice, I always would teach that T1 always gets a re-resection, and for high-grade TAs, I was always, if I did the resection, it depends on how big it is. This is the most specific data I've seen that re-resection on high-grade tumors makes a difference for all patients. And having quality benchmarks and checklists, I think, is a really helpful way to standardize and improve TURBT. So if you look at the consensus paper that looked at what it is that creates a high quality TURBT, there's a couple specific things, right? Having a note that describes what was actually seen, sizing, characteristics, predicted stage, doing an exam under anesthesia. I know Dr. Porton always emphasized that for us. Was it a visually complete resection? Did you perforate if you think you did? Could you see muscle in the specimen? And the idea of demonstrating or diagramming where the tumors are in the bladder or photos of your resections prior and after. So I adapted this into my op note. Every single TURBT that I do has all of these embedded into the op note. This is just one from last week. And I find that if I ever have to go back and see what things looked like in my patient, looking through the text and trying to figure out what was what is really cumbersome. So everything that I care about is put into a checklist at the very beginning, and then the text is basically just the text of what was done, and it's pretty standard. But this is the part that I emphasize for every patient. It makes it easier to go back because, as we discussed, unfortunately, these patients recur and you're in their bladders often. So this is staging TURBT. What about biomarkers? Can biomarkers help us do a better job for our patients? Well, the idea of using a biomarker is to add independent information about this patient or their cancer that can impact treatment. Biomarkers can be prognostic, which can tell you about their overall cancer outcome, regardless of what therapy they pursue or don't pursue, or predictive, meaning can they tell us how a patient will respond to a certain intervention that you recommend. The most interesting biomarker in the non-muscle invasive bladder space for me recently has been the CHI biomarker. That's put together by Valor Labs. It's sometimes called VESTA or CHI. But this is a histopath biomarker that's AI-based, looking at slides. And they've put together both a predictive and a prognostic biomarker. This is a recent evaluation just published in European Urology last month, looking at 269 patients who had high-grade TA, looking at this biomarker to predict high-grade recurrence-free survival and progression. And you can see if the biomarker was absent, that's the blue line, patients had a higher probability of recurrence-free survival compared to the biomarker being present, with really interesting and impressive separation of the curves. And you could also see here that in this group, about 10% of patients that were classified as intermediate risk would have been identified as having significantly higher risk of recurrence and progression, which again speaks to the fact that those high-grade TA tumors by behavior may not belong in the intermediate risk category, that a significant number of them will behave more like a high-risk tumor. So this is histopath. You need to do the resection to get this idea. You need to send this out. It takes a couple weeks. Fairly convenient, but still not as easy as we'd like it to be. What about the urine? We have the urine. That's an easy target. But urinary biomarkers have not advanced in the field as much as we would like. So what's the goal of a urinary biomarker? Well, in my opinion, you want it to improve upon your cystoscopy, maybe show you something that you can't otherwise see. Be great if they can be used to avoid cystoscopy altogether. Maybe we don't need to stick scopes in all these patients as frequently. And certainly maybe it could help clarify what is unclear to us on cystoscopy. Well, we've been using cytology for a really long time. That's been our very cheap, easily available biomarker. But the challenge for cytology is it's only effective in high-grade disease and misses quite a few of those. It is often atypical based on who is reading your cytology. It's very operator dependent, like most pathologic biomarkers. There's no objective standard, and certainly depending on who's on that desk, you might see differences in what you're getting reported. And it is not a point of care test, meaning you send that out after you've looked in the bladder, you tell the patient everything looks great, and then 3 days later it comes back suspicious for high grade or presence of high grade cells, and then you have to call the patient and say, well, I told you it looks great, but actually they found cells in the urine, and then you have to go through this whole thing. So it'd be great if you could have that result with the patient, in front of the patient, as opposed to after. If you look at the AUA guidelines, you'll see that at least at this state of the recommendations, they do not recommend using biomarkers in place of a cystoscopy or for low-risk disease, mainly because it's not as sensitive for low grade, and because the studies so far don't show that it is replacing a cysto evaluation yet. However, they do recommend or offer the possibility of using a predictive prognostic biomarker to assess response to BCG, so that is adjudicating treatment, or adjudicate equivocal cytology like Eurovision and immunocyt. This is the sensitivities and specificities for these markers that made it into the guidelines. There are several that have fairly similar sensitivity and specificities that have not made it into the guidelines yet. And there are even more that are not yet FDA approved, but new and exciting, including ones looking at urinary RNA, DNA, and protein. So while none of these are in the guidelines yet, this is something to keep an eye out for, because in the next few years, as this data becomes more robust, this is certainly something that'll enter in the conversation. As of right now, I think that the biomarkers don't play an active role in patient care, but there is this active problem that you get into when you use cytology, as I've discussed. When your cysto is normal and your cytology is not, then you certainly have a duty to assess for sanctuary sites of disease like upper tracts and prostatic urethra. This is a great place for blue light, where you can try to see, is there something you missed on white light cystoscopy? Or you could potentially use a biomarker to adjudicate that cytology that doesn't match your clinical assessment. Okay, we talked about epidemiology, we talked about diagnosis. Let's talk a little bit about treatment. Mainstay of treatment has been BCG for a very long time. If we look at the timeline of different intravesical therapies that have been approved, certainly starting with Thiotepa in 59, doxorubicin, BCG 1990, though it was used prior to that. The FDA approval was in 1990. Valrubicin, which is still used in Canada, less so in the United States. And then this slew of treatments that we've started talking about just in the last few years. The first intravesical one being approved is nadofaragene or Adstiladrin, then followed by nogapendican and Activa, and now TAR-200 in Lexo just this year. So if we go back and thinking about why BCG has been the cornerstone of our treatment for so long, it's because cancer cells preferentially take up BCG, and it has direct cytotoxic effects, inhibits proliferation, it modulates the immune response via numerous different cytokines, and it can stimulate a profound immune response in the bladder with release of T and B activation cells and independently natural killer cells. So it works on multiple different pathways to reduce bladder cancer recurrence and hopefully progression as well. But we also know with the experience that the BCG journey is long and cumbersome. It is also fairly toxic to patients. The treatments are pretty intense. I haven't had a single patient get through it without complaining about it at least once. And we know that it is under treatment for some patients and certainly over treatment for others who develop toxicity in the bladder, so much so that we have to stop or pause or reduce their treatments. And again, like I said, 30 to 40% of patients will recur or progress on it. So then there's this whole host of definitions of patients whose disease does not respond to BCG. And there's BCG refractory, relapsing, intolerant, unresponsive. But ultimately, there has been a consensus definition that has been developed by the FDA because we were able to convince them as a community of physicians that cystectomy is the standard of care for BCG unresponsive disease. And because that is a treatment that many patients don't want or are not candidates for, since that is a standard of care, the FDA has agreed that we can do single-arm studies because there is no real standard of care in this space. And that is what allowed all of these new trials to come forward. And the enrollment criteria for all of these trials have been exactly the same. They have been done to match this FDA definition that came out in 2018 for BCG unresponsive disease. And it's basically patients who develop high-grade T1 at their first evaluation following BCG, high-grade TA within 6 months of adequate BCG, or CIS within 12 months of adequate BCG. And adequate BCG is important. It's at least 5 of 6 doses of induction plus 2 of 3 of maintenance courses, or basically the minimum of 7 doses, whether it's in a maintenance course or if you started a second induction course and got at least 7 doses. So what did that lead to? That led to numerous FDA approvals and a fast track designation. So let's talk about these treatments that have been approved now. Pembrolizumab, not an intravesical therapy, certainly, but was the first one that was studied and approved in this case. Looked at two cohorts, CIS, with or without papillary disease, or papillary only. CR at 3 months, first assessment, is near 40%, but if you look at complete response at a year, it's near 19%, with a 13% grade 3 or 4 adverse event rate, with 8% of those being pretty serious and could be life-changing in this patient population. I've had a patient end up on dialysis after this. I had one patient develop myasthenia gravis after this. These can be really significant in a patient's life, and the cancer control is not quite worth it, in my opinion. So then nadofaragene came out. So nadofaragene is intravesical, instilled in the bladder once every 3 months, which is incredibly popular, especially for my patients who don't like to travel in the winter. And this is a non-replicating adenoviral vector-based gene that promotes a local interferon response. The CR at 1 year is a little better than pembrolizumab, about 24%, with a much lower, more favorable adverse event profile. Now, because nadofaragene was the first one in this space, they were very strict in their enrollment and the protocol that they employed for these patients. Namely, everyone was very concerned that if you don't treat these patients right away, they're going to develop metastasis, their disease is going to spread, they're going to progress to muscle-invasive disease. And so the way the protocol was written is if you don't respond to the first dose, meaning at the 3-month evaluation, if you don't have a complete response, you're taken off the trial. That's it, no more. We know with BCG that we reinduce people all the time, or we give people a little more BCG. Even with the BCG unresponsive disease, the 6 doses of induction is not enough to be considered adequate. You still need some of that maintenance dose. So a group of us with patients who have been using Adstiladrin for a little bit of time since its approval in December of 23 have pulled our data together. It's 8 institutions, still 17 patients, tiny, tiny numbers. But we have all, independent of one another, started reinducing patients with Adstiladrin, meaning if they didn't have a complete response at 3 months, some of us felt it was safe to do this again, meaning give them one more dose, see if that helps. And then retrospectively, we all looked at our data. And we saw that the 6-month recurrence-free survival is about 53%. And the cystectomy-free survival was 94%. No one died, no metastasis in this small patient population. So basically, we saw that you can salvage up to 38% of patients by giving them one more dose, getting them to a response, which is actually very similar to what you see from reinduction in BCG and with the subsequent treatments that I'll mention that did include this as an option in their protocols. So when you looked at the data for nogapendican, which is the BCG plus IL-15, so the BCG superagonist, this has a CR of about 45% at 1 year, with grade 3/4 AEs about 11%. So a little higher than nadofaragene, but also with an improvement in CR to match. And they actually reinduced patients of 28% successfully. This was built into their protocol. The de facto standard of care has been gemdosi. Certainly, it's been my de facto standard of care before these drugs were approved and for many patients even after the approvals. But we don't have prospective data for this. We have retrospective data with 1 and 2 year recurrence-free survivals somewhere in the, we believe, probably would be in the 40% range, similar to what we're seeing with nogapendican and TAR-200, as I'll mention, with a relatively low percent of disease progression. 4% of which had muscle-invasive disease on cystectomy. TAR-200 has now been approved. This was the highest numbers we've seen in the space when you look at overall CR. The FDA really loves to see that overall complete response rate. Clinically, I find it not to be very meaningful because I don't think a lot of patients care what their disease is like at 3 months. I think they care what what they're going to be doing a year from now. Are they still going to have their bladder? How miserable are they going to be? So I focus more on the 1 year response rates. And here it's about 46%, fairly similar to nogapendican. Adverse event rates, fairly similar to nogapendican. But this one is a device that you put in the bladder once every 3 weeks, as opposed to the BCG induction cycle. And I think sadly for nogapendican, the BCG shortage really hurt their uptake because people didn't have enough BCG to use for the BCG unresponsive groups. They've been saving it more for their BCG inductions to make patients eligible for all the trials and all the other subsequent therapies. Cretostimogene is not yet approved, though it does have an FDA fast track designation. This one I think is really interesting. It's got a very similar complete response rate as the other drugs that I've mentioned, but a much more favorable adverse event rate. Not a single patient dropped out, not a single patient had to stop or delay their treatments. It seems to be very well tolerated in the bladder, and it seems to have a really long curve. A tail end of the curve, meaning the patients who respond to this tend to have a durable response. So 74% of complete responders maintained their response for at least 6 months. So this is fairly exciting. And like I mentioned, the reinduction about 30% in this, which makes sense with immune-based mediators. So a couple caveats to all this, because this sounds kind of exciting, but these are all approved for patients with T1 CIS. That is one of the categories in BCG unresponsive disease. But if you look at the actual numbers of patients with this disease in these trials, they are tiny, very small numbers of patients. And even though the approval includes this category of patients, I'm not sure that it can really be translated to them with the same durability or complete response rates that we can promise our patients in the high-grade TA or CIS categories that don't have the T1. We definitely need more stage-specific trials for high-grade T1 CIS because it's its own animal. And just to sell that point even higher, this is a slide out of Dr. Kamat's talk several years ago that is probably the best way to picture this, and at least the way that I frame this to my residents, is high-grade T1 is the worst prostate cancer patient you'll see in your clinic. It is the one where you're going like this when you see that patient. And then we just call it non-muscle invasive bladder cancer and lump it into the same category for treatment with patients with, a 4-centimeter high-grade TA tumor or 2 patches of CIS. This is not the same thing. Biologically, this is a very different animal and it needs to be treated as such. So, where is the future? The future is everywhere. The future is quite broad in this space. The mechanisms that we are targeting in bladder cancer are expanding, but even our ability to stratify patients into groups is changing a bit more. We have several trials that are ongoing for intermediate risk non-muscle invasive bladder cancer, whether that's adjuvant trials, so trying to treat a resected bladder to reduce recurrence, or something like UGN 102, the Envision trial now approved at Zosturi, where you can even avoid doing a TURBT in the first place, where you put a mitomycin hydrogel into the bladder with the tumor intact to chemically ablate this tumor. I don't think a huge number of patients are going to be candidates for this with uptake in the community, but I do think for your VA patients on oxygen, on anticoag, 2 strokes, who still really want to treat their bladder cancer, this can be a really safe option and a better option. For patients in the BCG naive space, finally, we're trying to challenge BCG as the gold standard. So the Bridge trial, which was looking at Gemdosi frontline versus BCG, has finished enrolling, and we will have the readout of that trial in the next year and a half once they accumulate enough events to comment. This trial was designed as a non-inferiority trial, so it's hard to say if it'll actually unseat BCG as king just based on the design of the trial, but certainly it'll be provocative enough, and it may end up having to change how some of these definitions were structured, because right now numerous patients who have gotten inadequate BCG but were transitioned to Gemdosi or only got Gemdosi from the get-go because of BCG shortages are not eligible for many of these clinical trials, or for some of these drugs that are now FDA approved, where insurance will sometimes balk and say where you didn't meet this definition, even though clinically we've learned to treat these somewhat equivalently, and the bridge trial will help us with that. Potomac and CREST, these are the trials that said, can we intensify treatment? So can we take BCG plus a systemic agent and reduce recurrence and progression in the frontline setting? Potomac has read out positively, though we don't have the details of that. CREST certainly has been published and presented at the AUA last year, showing a couple of important things. One, it's very hard to get patients through BCG in 3 years of maintenance, even on a clinical trial, which we all know from our practice settings. Two, the adverse event rates of PD-1s are real, and the systemic toxicity is certainly something to discuss with patients, because despite several years of our experience of handling these drugs, the adverse event rate of about 10 to 13% is what we're still seeing in current data, which is no better than it was when Pembro was first trialed 5 years ago now in this space. And the benefit was really about 7 to 8%, meaning the event-free survival changed for less than 10% of people, fewer patients that experience significant side effects. So I think the uptake of that in the community is not going to be tremendous. And certainly in the BCG unresponsive space, I gave you the drugs that are already approved, but as you can see, cretostimogene has several trials that are ongoing. Quilt is the Anktiva-based trials. They have some additional trials in the space. There is more sunrise trials, which are not factored in here, but the Janssen trials using the pretzel in the BCG naive space and in the papillary space as an unresponsive are ongoing. So there is more to be seen in this space for sure, that's taking advantage of all the different mechanisms that we've talked about. We know that BCG is effective because it harnesses many different pathways and mechanisms, but there are even more to be explored, certainly with all the plasmid technology. So very, very exciting, except we know that the costs are absolutely compounding with every single one of these marginally improved interventions. Gemcitabine docetaxel is, the cost of parking for most of these patients, but every single one of these other treatments are absolutely astronomical. When nadofaragene came out at $60,000 a dose, people were saying this was insane. This is $60,000 per dose once every 3 months, so 4 doses a year. TAR-200 needs to be put in every 3 weeks, and it's $70,000 a dose. These are truly astronomical. And a recent Markov decision analysis tried to look at these 5 treatments that were FDA approved at the time that we did the analysis. So cystectomy, nadofaragene, nogapendican, Pembro, and Gemdosi, and evaluated cost effectiveness over a 5-year period, having some caveats of how much someone's willing to pay, a threshold of about $100,000 per quality. But basically, for index patient 1 who was willing to try one line of therapy or proceed directly to cystectomy, far and beyond, gemcitabine docetaxel was the most cost-effective option. For index patient 2, who's open to 2 lines of therapy or upfront cystectomy is the most effective option. And for index patient 3, who is willing to try up to 2 lines of FDA-approved therapy only, meaning you can't use Gemdosi because that's not FDA approved, pembrolizumab came up as the most cost-effective. A, because it came out earlier and cheaper, but B, because it doesn't work so well. You can only use it for a year and you have to move on. So the challenge with this is we're making relatively marginal gains at a horrific price to the healthcare system and to our patients, because a lot of patients are having to pay copays and deductibles to supplement these treatments, and it really is devastating. And then last year, I can't not mention this, that Dr. Gore and Dr. Smith presented the results of the Cysto study, which is patient survey data. So this is direct patient interviews and patient surveys trying to understand patient values, preferences, and functionings of patients who elected to undergo bladder sparing therapy and radical cystectomy. And as much as we can talk about, we were able to keep bladders in for 12 more months, 18 more months at a cost of $200,000, $500,000. When you look at what the patients are saying, it was impressive to see that with respect to physical functioning, cognitive functioning, financial, mental health, and recurrence-free survival, right? The cancer outcome, all of that favors radical cystectomy. The only things that favor bladder sparing, what we've been fighting for so long with all of these different drugs and trials, is sexual health and bowel health, which makes sense because those are the things that our cystectomies are continuing to impact despite our improvements in techniques. And certainly, I think we're making gains in that with different approaches and robotic surgery and all that. I think that those domains are still going to be the most impacted. So to wrap this up, we talked about risk factors for non-muscle invasive bladder cancer, how they're changing. We talked about risk stratification, talked about the role of enhanced cystoscopy and biomarkers, because we know that risk groups alone are not enough to help us predict what our patients are going to face, given the recurrence and progression factors and percentages that we're seeing in this population. We talked about some new and emerging, potentially exciting strategies. But sadly, there is no neat wrap up to this story because the story is absolutely still evolving. There is still so much we have to learn along every step of the landscape with risk, with stratification, with our techniques, both surgical and medical. And finally, we have to go back to the patients, because if we put all of our eggs into this very, very expensive, slowly moving basket, and that doesn't meet the needs of our patients, then really we haven't helped the most important patients on this journey.